Okay. Yeah, all right. All right. Okay. All right. So this is a short session where we're gonna talk about the revision or a quick revision of the radiology, as well as the majorly focused on the images that we get in the radiology. As we know that we have done the radiology in a pretty detailed way, and I'm very confident that if you're just gonna quickly revise your notes, you will be able to answer almost every question that is asked in the exam. However, in the next 1.5 to 2 hours, what we're gonna do is we're gonna try to go to all the pattern of image-based questions that can be asked in the exam. And I'm very confident that the session that we will be doing now is gonna give you 10 to 15 extra questions in the paper. So um, just make sure that you are attending it properly. Okay, so let us go ahead without wasting much of our time. So this is the first pattern of question that you can get in the exam. Examiner can give you this kind of image and they can simply ask you that name the investigation. Okay, what is the name of the investigation? You can put me into the WhatsApp or into the Telegram or into the comment section of the app, that what do you think is this particular image. Now this is a common question when the examiner gives you an image and the only question that they ask you is name the investigation. Okay, so what do we see in this? I think all of you can appreciate that this is a cross-sectional image. This is a transverse section of the pelvis. And I think all of you will agree with me if I'm going to say that these structures are the iliac bone and the sacrum. Please remember, if the cortical bones are so white, mark my words, if the cortical bone is so white, it has to be a CT scan. So these images are images of CT scan. This is not an MR. On MRI, cortical bone is black, whereas on CT scan, cortical bone is white. So this is a CT scan of pelvis, which is taken in a transverse section or in an axial plane. On the other hand, if you're gonna see this particular image, anybody who can tell me what is this image? Now this is the brain. This is the sagittal section of the brain. When you have taken the brain in this plane, now do you see this white structure and you're thinking it is a cortical bone. What you're not realizing is that's not the cortical bone, that's scalp. So this is cortical bone, and if the cortical bone is black, this image is MRI. Okay, so let's go back once again. This is a prototype image for a CT scan, whereas this is a prototype image of an MRI. Okay, so CT scan and an MRI, this is a transverse section and this is a sagittal section. I hope all of you can easily appreciate it. Now there are two more images for you, image number 1 and image number 2. Anybody who can tell me which one is a CT and which one is an MR? Image number 1 and image number 2, which one do you think is CT and which one do you think is an MR? I think all of you will agree with me that in both the images, cortical bone is white or black. Anybody? Cortical bone is white or black. So again, do not mix it. This is scalp. This is scalp. This is cortical bone. This is cortical bone. And in both the images, cortical bone is not white but black. And if the cortical bone is black, this is an MRI and this is also an MRI. If both the images are MRI, then what is the difference between them? Now, I want you to pay attention and I want you to focus on this area. And I think all of you will agree with me if I say these are ventricular system, correct? And if the ventricular system is black, we know ventricular system contains CSF and a CSF. So just remember one word, and that is World War II. World War II. Now what is World War II? Water is white on T2. Water is white on T2. No structure can be more white than water on a T2 weighted MR. No structure can be more white than water on a T2 weighted MR. Water is virtually hyper intense to everything on a T2 weighted MR. Water is virtually hyper intense to everything on a T2 weighted MRI. So remember World War II. So this is a T1 weighted MRI and this is a T2 weighted MRI. And I want all of you to be aware of that. there are chances that somebody may ask you this question in the exam, that not just an MRI, which one is a T1 and which one is a T2, look at the water. If the water is black, it is T1. If the water is white, it is T2 weighted MRI. Anybody who can tell me what is the name of this investigation? Is it a CT or is it an MRI? What is the name of this investigation? So please remember that this is neither a CT nor an MR. If you see this kind of an image, we are talking about ultrasound. This image is an ultrasound image. Okay. In this year INI CT exam, they asked an image of the ultrasound and the question was, what is the name of the investigation? And that is what is expected from an undergraduate student who is not a radiologist, that they should be able to identify the investigation that has been done. I think all of you are smart enough and can pick up that this is an ultrasound. Okay, but what next? Anybody who can tell me that which body part is being scanned? Now the point to be noted is it is not always possible to identify which body part is being scanned, but in some of the areas it can be done, like in this case. So please remember, this structure that you could see here is liver, and I think most of you can appreciate that this is liver. Now my question to you is the structure that I have marked as 2. Anybody who can tell me what is the structure that is marked as 2? What do you think is 2? The number 1 is liver. Now you have to tell me what is number 2. Okay. So if you are thinking that the number 2 is gallbladder, you are wrong. This is not gallbladder. It is to be noted that the gallbladder will be a pier-form structure which will be jet black from inside. Gallbladder will be a pier-form structure which will be jet black from inside, whereas if you see a reniform structure like this, this has to be kidney. This has to be kidney. Yes. So one is liver and the other is kidney, and in between the liver and the kidney we have a space which is called as, anybody who can tell me what is the name of this? This is called as a hepato. Hepato means liver. Renal. Renal means kidney. Hepatorenal pouch. Hepatorenal pouch, also called as, what is the other name for hepatorenal pouch? Anybody who can tell me? Other name for hepatorenal pouch is Morrison's pouch. Morrison's pouch. Now I'm giving you a statement. You have to tell me whether this statement is true or false. A quick answer. Okay, in a fraction of a second. The moment I stop, within 2 seconds, I am expecting an answer from you. Now tell me, Morrison's pouch is the most dependent part of the peritoneum in erect position. Morrison's pouch is the most dependent part of the peritoneum in erect position. Tell me whether it is true or whether it is false. Morrison's pouch is the most dependent part of the peritoneum in erect position. So please remember, that's a false statement. That's a false statement because Morrison's pouch is the most dependent part of the peritoneum in supine position, not in erect position. Not in erect position. So these are the points that you need to pay attention in the MCQ exam, which we do wrong. And now see how many of you gave me the wrong answer. And all those who have given me the wrong answer, now just think about that. And now a lot of you say, "Arey, sir, नहीं, yeah. Erect में पाउच ऑफ डगलस होता है, सुपाइन में मॉरिसन्स होता है." और मैं बोलूंगा, बच्चे मेरे करेक्ट करने से पहले ठीक करना था ना. You should have done it correct. Before I would have objected to it, because the rule of an MCQ paper is you don't get a second chance. You have to correct, you have to pick up the answer in the first go. So please take care of these small points that are there. Okay, I think you can identify that this is an ultrasound. Alright. A contrast study is something which is a favorite question of the examiner, and I have seen over a period of time is one image will always be there in the paper. Like for example this. Though we have discussed this in great detail in our classes, but sometime if you missed it, now let us do it now once again. So you can see the dye. Just identify where do you see the dye. If you are seeing the dye in kidney, ureter and bladder, please remember kidney, ureter and bladder, this investigation has to be IVP. Now what is an IVP? Intravenous pyelography. intravenous pyelography, also called as IVU, intravenous pyelography or intravenous urography, intravenous pyelography or intravenous urography. Okay, what do you see is this? I can see the dye opacifying the, what is this structure? Do you think it is urinary bladder? Anybody who can tell me, is it urinary bladder? True or false? Tell me, is it urinary bladder? You can see a radiograph of the pelvis. You have to just tell me whether it is urinary bladder. True or false? So false. This is definitely not urinary bladder. This is uterus. This is uterus, and these two structures that you could see are the fallopian tubes. So if you are seeing the opacification of the uterus and the fallopian tube, what is the name of the investigation that we are seeing? We are seeing HSG. Now what is HSG? Hysterosalpingography. Hysterosalpingography. Okay, so that is an HSG, and that is how a normal HSG looks like. As you could see, a free intraperitoneal spill. The moment I see a free intraperitoneal spill, that means the tubes are patent. The moment I see the spill, that means the tubes are patent. Alright, now what do you see here? I can see the opacification of, now we can see a urinary bladder. I can see urethra. Okay, you can see the prostatic urethra, membranous urethra, bulbar urethra, and penile urethra. So when we see this, I know that I am dealing with a case of, is anybody? MCU. MCU. What is an MCU? Micturating cystourethrophy. MCU, micturating cystourethrophy, which is a very, very good investigation for evaluation of posterior urethra and vesicoureteric reflux. A very, very good investigation for the evaluation of posterior urethra and vesicoureteric reflux. So this is an MCU. Now it is to be noted that MCU shows you the posterior urethra very, very well. Very, very well. However, if you want to see anterior urethra, as it is so very well depicted over here, which is the penile urethra, and this part, which is a bulbous part, is a bulbar urethra, then this investigation, the contrast is retrogradely injected. Anybody who can tell me what is the name of this investigation? RGU. RGU. What is an RGU? Retrograde urethrophy. This is nothing but an RGU, which is a retrograde urethrophy. Okay, so just see once again, this is an IVP, this is an HSG, MCU, and RGU, retrograde urethrophy. I hope I am clear, and I hope I am not very, very fast. I hope you are able to grasp the speed. I am deliberately trying to be very, very slow, because I do not want any of you to do this question wrong in the paper. These are free marks in the exam, and everybody should grab these free marks. Okay. All right. Second important point that I want all of you to be aware of is related to the COVID. Please expect one question of the radiology related to COVID in one form or other. Okay, before I go into the detail, I want you to write it into the comments. Anybody who can tell me a patient has a CT CO-RADS score of 4 and a patient has a CT CO-RADS score of 2. Anybody who can tell me which has got a more severe disease? A patient has a CT CO-RADS score of 4 and a patient has a CT CO-RADS score of 2. Anybody who can tell me which has got a more severe disease? Quickly tell me the answer. CO-RAD 4 or CO-RAD 2? Quickly tell me who has more severe disease. So very, very good, Shweta. CO-RAD does not tell me about the severity, and that is what I was looking for. Very, very good. I am very happy that a lot of you have given me the correct answer. CO-RAD does not tell me the severity. It does not decide the severity. So a lot of you have given me the correct answer, but since I can only see one name that was coming, and that is why I do not know why that name was coming. There's no name is coming. Okay, all right. So maybe you people have not written your correct name on the WhatsApp, and that's the reason. Okay, all right. So, but yes, I'm very happy to see that a lot of you have given me the correct answer. So, CORAD does not tell about the severity. CORAD does not tell about the severity. So, what is CORAD? It's a degree of probability of COVID. This was this year INI state question, but please expect such kind of question in your screening paper as well. So we have got 5 CORADs. CORAD 1 means normal CT. That means the CT does not have any changes. Can the patient still have COVID? Answer is yes. I had a proven COVID infection, but my CORAD score was 1. My CORAD score was 1 because my CT was normal. CORAD 2. CORAD 2 means that there are changes in the CT which are favoring some other infection. Which are favoring some other infection. Okay. CORAD 2, like what are the common points that I want you to remember is pleural effusion. Please remember that. Pleural thickening, cavitation. Pleural effusion, pleural thickening, cavitation. All these are signs that suggest an infection other than COVID. So we see these changes. We label them as CORAD 2. That means there are changes in the CT which are reflecting some other disease. CORAD 3 is indeterminate. Now, what is the meaning of indeterminate? That there are changes which can be seen in COVID, however, it can be seen in some other disease also. So, it's an unclear whether the COVID is present or not. Whereas CORAD 4, the chances of having COVID is more likely. Whereas CORAD 5 means that it is almost typical for COVID. And this is also that I want you to remember. What is a typical finding of COVID on the CT is multifocal peripheral areas of ground glass opacity in basal lungs. Multifocal peripheral areas of ground glass opacities in basal part of the lung is CORAD 5, and that is considered to be typical of COVID-19. That is considered to be typical for COVID-19. CORAD 6 is RT-PCR proven COVID. It's RT-PCR proven COVID. So the point that I want you to remember is CORAD does not tell me the severity. Okay. All right. Now this is also a very favorite question of the examiner when give you this image and they will ask you, okay, tell me the name of the investigation. So anybody who can tell me what is the name of these investigation, image number 1 and image number 2. Yes, please. Yeah. So whenever you see the vessels, the first answer that should come to your mind is angiography. Okay, angiography. Okay, before I go to this image, I will want to show you a different image. This is again image number 1 and this is image number 2. Anybody who can tell me which one is an angiography? Image number 1 and image number 2. Which one do you think is an angiography? So if somebody asks me, I will say both. Both are angiographies. Okay, both are angiographies. But the difference is that the image number 1 is a radiograph and image number 2 is a CT scan. Image number 1 is a radiograph. Image number 2 is a CT scan. Now the point to be noted is if it's a radiograph, it's a catheter angiography. If it's a radiograph, it's a catheter angiography. If it's a CT scan, it's a CT angiography. If you are seeing an angiography on a background of an X-ray, that is a radiograph. If you are seeing an angiography on the background of the CT scan, this is a CT angiography. CT angiography. Okay. Now the point to be noted is, please see this image. Now, in these two images, I cannot see a background. It is so easy to see the background of a radiograph here and the background of CT scan over here. But in these images, I don't see a background. Now, what has happened is, in these images, the background is subtracted. And these are called as subtraction angiographies. Now, these are called as subtraction angiographies. Now, point is, if it's a non-subtracted angiography, it is very, very easy to differentiate which one is a catheter angiography, which one is a CT angiography. However, if it's a subtracted image, then it will be very, very difficult to identify. And then we're going to use a cheat code. And what is that cheat code? Look at the colors of the vessel. If the color of the vessel is white, it's a CT and it's a CT angiography. If the color of the vessel is black, it's a catheter angiography. It's a catheter angiography. So you can identify it on the basis of color, whether it's a CT angiography or whether it's a catheter angiography as well. Are you getting it? Okay. All right. Okay. Anybody who can tell me what is the name of this investigation and what is the diagnosis? Anybody who can tell me what is the name of the investigation and what is the name of the diagnosis? Okay. Now please see, this is a radiograph and you can see it's an aorta. So there is an angiography and this is renal artery. So this is a renal artery angiography. It's a renal artery angiography. And what do we see is a marked narrowing at the origin of the renal artery. So this is a classical image for renal artery stenosis. It's a classical image for a renal artery stenosis. यहाँ किडनी सी दिख रही है तो किडनी में जो आर्टरी जाएगी वो कौन सी आर्टरी होगी? renal artery होगी, है ना. आईवीपी नहीं मार्क कर देंगे इसको, है ना. आईवीपी में यूरेटर दिखेगा जो ऐसे जाएगा, है ना. So this is an angiography because I am seeing the arteries. Is it okay? है ना. These are the mistakes and these are the points that we have to be aware of. Okay. Image number 1 and image number 2. Leave image number 3. Anybody who can tell me which one is what? So I think all of you can identify that the first image is an MRI and the second image is also an MRI. And I think all of you can also tell me that this is a T1 weighted MRI and this is a T2 weighted MRI. So T1 weighted MRI and a T2 weighted MRI. Are you getting it? World War II. Okay. Next point. A very, very common question that is asked in the screening exam is an anatomy on a radiological image. Examiners are very fond of asking this. What they're going to do is they're going to give you a radiological image. They're going to mark a normal anatomical structure and they ask you what is the name of that anatomical structure. The commonest image that they ask you is a mid-sagittal section of the brain, which I am showing you over here. So let us try to mark some of the structures over here. What I'm going to do is I'm going to labeling them and I want you to tell me what are the structures that I have marked. Okay. So I am marking as 1, 2, 3, 4, 5, 6, 7, 8, 9 and 10. So there are 10 structures that I have marked and I want all of you to tell me what are these structures. If you can mark these 10 structures, your anatomical understanding on a radiological image is correct. Okay, I think it should be clearly seen. I think I can see it very, very clearly. Just increase the brightness of your screen if you can't see it, but I'll still use another pen. Okay, so image number 1 is frontal sinus. Number 2 is corpus callosum. Corpus callosum. Number 3 is midbrain. And just tally which all you did right and which all you did wrong. Number 4 is pons. Number 5 is medulla. Number 6 is fourth ventricle. fourth ventricle. Number 7 is cerebellum. Number 7 is cerebellum. Number 8 is pituitary gland. Number 8 is pituitary gland. Number 9 is pineal gland. Number 9 is pineal gland. And number 10 is sphenoid sinus. And number 10 is sphenoid sinus. Which one will be asked in the exam? That I do not know, but it does not matter because we know all. Whatever they're going to ask, you can simply mark the correct answer without a doubt. Is it okay? Alright. So that's the sagittal section of the brain. Another section that they very commonly asked is a transfer section of the brain, and specifically at the level of basal ganglia. So the structures have already been marked over here. I will just label them. Okay. So structure number 9 is lateral ventricle. Okay, it's a lateral ventricle, which is a CSF filled space, and it's a, to be more precise, it's a frontal horn of lateral ventricle. Frontal horn of the lateral ventricle, and to be more precise, this side is right. So it's a frontal horn of a right lateral ventricle. So this is the right lateral ventricle and this is the left lateral ventricle. The two are joined at the level of a foramen, and which is called as foramen of anybody? Monro. Foramen of Monro. Okay. Then you see this oval shaped structure adjacent to the lateral ventricle, and what is that structure? That structure is, yes, anybody? Caudate nucleus. This structure is caudate nucleus, and this triangular shaped structure that you could see here is, yes, is lentiform nucleus. It's lentiform nucleus which has got a medial part and a lateral part. It is to be noted that the medial part is called as globus pallidus. ये सब पढ़ाया हुआ है मैंने आपको. I have taught you all these things. It's a revision class that is happening. So I expect you to give me the correct answers. Lateral part is putamen. Medial part is globus pallidus. The lateral part is putamen. How will you remember it? P for peripheral, P for putamen. P for peripheral and P for putamen. Okay. And this oval shaped structure on either side of the midline is thalamus. And if you see this, a bow shaped structure between them is a white matter tract. And what is that white matter tract that we have? Internal capsule. This white matter tract is nothing but the internal capsule. Okay. All right. So these are the some of the structures on a transfer section of the brain. Caudate nucleus is something which is very, very frequently asked as foramen of Monro, lateral ventricle, lentiform nucleus. These are the ones which are usually asked in the exam. Okay. From the brain, the examiners are very fond of asking images of the chest. As you could see that this is the transverse section of the chest and this is the coronal section of the chest. Since the bones or the cortical bone or the vertebra is so white over here, I don't think there will be any challenge in identifying that this remains a CT scan. CT scan. Now the point to be noted is, if you see a CT scan of the chest, your knowledge should not be limited to know that this is a CT scan or not. Rather, you also have to tell whether it's a non-contrast CT or a contrast enhanced CT. So anybody who can tell me by looking at this image that whether it's a non-contrast CT or whether it's a contrast enhanced CT and why. Why if I say that it's a non-contrast CT and why if I say it's a contrast enhanced CT. Anybody who can give me the answer. Yes. So the point to be noted is look at the aorta and look at the paraspinal muscles. So always, whenever you have a doubt, whenever you want to compare or whenever you want to identify whether it's a non-contrast CT or a contrast enhanced CT, compare vessel with a muscle. Compare vessel with a muscle. If the vessel is wide than the muscle, it has to be a contrast enhanced. If the vessel is wide than the muscle, it's a contrast enhanced. If the vessel and muscle are of exactly same color, it's a non-contrast CT. If the vessel is white than the muscle, then it's a contrast enhanced CT. If the vessel and muscle are of exactly same color, then it's a non-contrast CT. Okay. Now the point to be noted is it is 1, it is 2, it is 3, it is 4. 1, 2, 3, 4. Okay. Now there are 4 chambers of the heart and you have to tell me which one is what. Which chamber is what. So if I see this is anterior, this is posterior, this is right and this is left. Anterior, posterior, right and left. Now the point to be noted is that we have to just imagine, and we know that the posterior most chamber of the heart is left atrium. So since fourth is the posterior most chamber of the heart, the fourth becomes left atrium. And if the fourth is left atrium, the 3 is very easy to identify. That 3 is the left ventricle. And if the 3 is the left ventricle, it is very easy to identify that the 2 is right ventricle. And if the 2 is right ventricle, it is very easy to identify that the 1 is right atrium. The 1 is right atrium. Okay. So that is how you have to link it. If you do not know the chambers, all 4 chambers, and if I'll tell you one, it will be very easy to identify the other 3 chambers. And that is what happens with our knowledge also. A lot of time you are unable to recall. And whenever you are unable to recall, try to link the informations. The more you are able to link the information, the easier it will become for you in the life. Okay, just try to do that. Okay. Now from the chest, let's move to the abdomen. And I think in the abdomen also you can identify the name of the investigation. Anybody who can tell me what is the name of this investigation? Again, this is a CT scan. So please remember, in the brain, it is not mandatory for you to identify whether it's a non-contrast or a contrast enhanced CT. In the brain, it is not important for you to identify whether it's a non-contrast or a contrast enhanced CT. In the chest, you have to tell whether it's a non-contrast or a contrast enhanced CT. Whereas in the abdomen, you also have to know whether the contrast is oral or IV or both. Whether the contrast is oral or IV or both, you have to tell. Now, how will you tell that? Again, this is very simple, not a very big deal. Now, the vessel versus muscle will tell you IV contrast. If the vessels are wide than the muscle, there is an IV contrast. Now, look at the bowel loops. If the intraluminal content in the bowel is whitish, oral contrast has also been given. Oral contrast has also been given. So the point to be noted is, if the oral contrast is given, it's an oral contrast. If the IV is given, it's IV contrast. If both are given, it's oral as well as IV contrast. So this CT scan is done with oral as well as IV contrast. Okay. So now let us see some of the structures that we could see in this. I think all of you can appreciate that this is nothing but the right-sided structure, which is liver, whereas this is spleen. I don't think there should be any problem in identifying. This is kidney, which is the right kidney, and this is the left kidney. The structure that is there in the center is aorta. And is aorta. All of you can easily appreciate that. My question to you is, what is this linear structure which is showing contrast within? What do you think is this structure? What is the structure? So please remember, this parallel structure, a vessel, is a portal vein. It's a portal vein. Now, if you're thinking this is a gallbladder, please remember this is not a gallbladder, because gallbladder will appear hypodense on CT. Gallbladder will appear hypodense on CT, and that is I want all of you to be aware of. Is it okay? All right. All right. So that was the basic anatomy on a radiological section that I want all of you to be aware of. Sometimes the examiners are also very fond of asking some of these anatomy, like they will give you the chest x-ray, and on a chest x-ray they will mark a bone and they will ask you what is that bone, like they will mark a coracoid process. I think you will be able to pick up the coracoid process of the scapula, or the acromion process of the scapula. They might give you the X-ray of the elbow joint and they mark a medial epicondyle or a lateral epicondyle or a trochlea. Or they can give you the X-ray of the hand and they can ask you a carpal bone. And they can ask you, she looks too pretty, try to catch her. Something like that. So please make sure that you are able to do that. Okay. So now once you are able to do that, now let us go to some of the diseases which the examiners are very fond of asking. Now in the diseases, the one thing that the examiners are very fond of asking is neuroradiology. Okay, neuroradiology image-based questions are the hot shot for the examiner. Okay, so before I go into that, let us remember some terminologies. Okay, so the terminology is very simple. I want all of you to make this chart, and this chart will help you. Okay, and it's a 3 by 3 table, 3 by 3. Now what is that? Please remember, anything that will appear black in the radiology will be labeled as hypo. Anything that is white in the radiology will be labeled as hyper. Anything that is black in the radiology will be labeled as hypo. Anything that is white in the radiology will be labeled as hyper. Okay. If it is ultrasound, the terminology will be echoic. If it is CT scan, the terminology will be dense. If it is MRI, the terminology will be intense. If it is ultrasound, the terminology is echoic. If it is CT scan, the terminology will be dense. And if it is MRI, the terminology is intense. If it is black, it is hypo. If it is white, it is hyper. Okay. Now, how do we decide whether it is black or white? That's a reference. And anything similar to the reference is gonna taken as ISO. So please remember the terminology in ultrasound is hypoechoic, hyperechoic. So hyperechoic will be white, hypoechoic will be black. The terminology in ultrasound will be echoic. In CT, it is dense. In MRI, it is intense. In MRI, it is intense. That's the point that I want all of you to be aware of. Okay, all right. So now let us see this. So there are 3 CT scans for you over here. Please remember, the moment you see a CT scan, the terminology that will be here is dense. The terminology that will be here is dense. Dense means CT scan. And you could see biconvex hyperdense collection. If you are seeing a biconvex hyperdense collection, you are dealing with a case of EDH. You are dealing with a case of extradural hemorrhage. And what kind of extradural hemorrhage? Acute. Why acute? Because it is hyperdense. It's a very commonly asked image in the exam. Whereas in this case, what do we see is a crescent shape hyperdense collection. And the moment you see a crescent shape hyperdense collection, your answer is SDH. SDH. So biconvex is EDH, crescent shape is SDH. Now the point to be noted is, if you are seeing the linear hyperdensities along the sulci, what you are dealing with blood in CSF. Because sulci contains CSF. If you are seeing blood in the CSF, what you are dealing with a case of a subarachnoid hemorrhage. You are dealing with a case of a subarachnoid hemorrhage. So we have an EDH, you have an SDH, and you have a subarachnoid hemorrhage. Subarachnoid hemorrhage. Very important that I want all of you to remember without a doubt. Okay. Whereas what do we see here? Now in this case, you are seeing a hyperdensity within the brain parenchyma. And if you are seeing a hyperdensity within the brain parenchyma, this is intraparenchymal hemorrhage. Intraparenchymal hemorrhage or an intracerebral hematoma. Intraparenchymal hemorrhage and an intracerebral hematoma. Whereas what do we see here is small foci of hemorrhage at gray white matter junction. Small foci of hemorrhage at gray white matter junction. If they see small foci of hemorrhage at gray white matter junction, then this is a case of diffuse axonal injury. This is a case of diffuse axonal injury when you see tiny foci of hemorrhage at gray white matter junction. But this is not a pontine hemorrhage. Why this is not a pontine hemorrhage? Because this transfer section is not taken at the level of pons. Pontine hemorrhage will only be seen when you are seeing a section at the level of pons. So this is a much higher section. So this is a hemorrhagic foci at the gray white matter junction, which is a feature of diffuse axonal injury. Now it is to be noted that in diffuse axonal injury, in more than 80% of the cases, CT is normal. In more than 80% of the cases, CT is normal, and that is why the investigation of choice to diagnose diffuse axonal injury is MRI. Okay. Now, after the hemorrhage, a very important image is that is asked in the exam is a calcification pattern in the brain. Examiners are very fond of asking these questions. Calcification pattern. So what are these? These are the special calcific patterns on the basis of the location, and that can help you in reaching to a particular diagnosis. What do you see in this? Now this is ventricular system, and you are seeing a calcification. You are seeing the calcification along the ventricular system. And this is a periventricular pattern. This is a periventricular pattern, which is a feature of CMV infection. Periventricular pattern, which is a feature of CMV infection. Here you're going to see this. Here is a diffuse nodular pattern. Okay, this is a diffuse nodular pattern. Now, this diffuse nodular pattern is seen in toxoplasmosis. Diffuse nodular pattern is seen in toxoplasmosis. Whereas in this case, what you are seeing is a bracket pattern. And this bracket pattern is seen in corpus callosal lipoma. Okay. If you see small foci of calcification scattered in the brain parenchyma, do you remember? See, we have done all this in great detail in our class. As I told you, it's just a revision. So I need quick answers from you. Okay, there is no point having the class if you are not giving me the correct answers. Because this is a revision class that is going on. Starry sky pattern. What's a starry sky pattern? Starry sky pattern is seen in neurocysticercosis. Okay. If you see small calcification along the ependymal lining, this is called as subependymal calcific nodules. Subependymal calcific nodules, which is also called as candle dripping appearance. Which is a feature of tuberous sclerosis. A candle dripping appearance, which is a feature of tuberous sclerosis, and if you see calcification along the gyri, which is called as a gyral pattern, also called as tram track pattern. A gyral pattern or a tram track pattern, this is a feature of Sturge-Weber syndrome. A gyral pattern or a tram track pattern, which is a feature of Sturge-Weber syndrome. Sturge-Weber syndrome. Okay. Calcification pattern is something which is very, very frequently asked. Apart from that, the shape of the skull is also, which I have seen examiners are very, very fond of asking. So now let us see some quick shapes of the skull that are asked, and I will not tell anything. You will tell me. I am just naming them 1, 2, 3, 4, 5, 6. Tell me quickly what are these shapes that have been shown to you over here. What are these shapes? 1, 2, 3, 4, 5, 6. So what is 1? 1 is a punched out lytic lesion. One is a punch out lytic lesion, also called as raindrop appearance of multiple myeloma. Punched out lytic lesion, also called as raindrop appearance of multiple myeloma, whereas 2 is geographic lytic lesion. Geographic lytic lesion with beveled edges. Geographic lytic lesion with beveled edges, which is seen in eosinophilic granuloma. Geographic lytic lesion with beveled edges seen in eosinophilic granuloma. Third is silver beaten appearance. Silver beaten appearance, which is seen in raised intracranial tension. Silver beaten appearance, which is seen in raised intracranial tension. Whereas 4 is hair on end appearance. Hair on end appearance, which is a feature of thalassemia. Hair on end appearance, which is a feature of thalassemia. Whereas if you look at a 5, 5 is salt and pepper. Okay, do not confuse these two. Salt and pepper is like somebody has sprinkled some salt and pepper, which is like a grainy appearance. Whereas in a punched out lytic lesion, you see well-formed lesions over there. Okay. Salt and pepper appearance is a feature of hyperparathyroidism. Hyperparathyroidism. And the 6 is cotton wool skull. Cotton wool skull, which is a feature of Paget's disease. Cotton wool skull, which is a feature of Paget's disease. Cotton wool skull, which is a feature of Paget's disease. Okay, all right. So these are the some of the important points from the neuroradiology that examiners are very fond of asking, specifically in the foreign medical graduate screening exam. Shape of skull, calcification pattern, and the various trauma patterns in the brain. They should be on your tips. I do not want any of you to commit a mistake on this. Okay. Now from the brain, let's keep on going down and let's reach to the neck region. In the neck region, examiner can give you a radiograph and can ask you various kind of questions related to the radiograph. So I think all of you should be able to identify that these are the radiographs, and more importantly, this is the lateral radiograph and this is the frontal radiograph. Okay. Now obviously depending on the history, which will help you in picking up an answer, but there are few important points that I want you to pay attention to. These structures are the bones. This black structure is an airway, and rest all is soft tissue. Okay, so first, whenever you are seeing a pathology, you should be able to divide them into these three groups, whether it's predominantly a soft tissue pathology or an airway related pathology or a bony pathology. The bony pathology that can be shown to you in a radiograph is the slippage of the vertebra over another. So normally the vertebrae are aligned. The vertebra can slip over each other. So they can show you that. So for that, what you need to see is you need to draw a line. The anterior and posterior vertebral line should be continuous. It can be curved, but it has to be continuous. Then this soft tissue, which is behind the pharynx, should be less than the width of the vertebra. If this is increased, the disease that you're talking of is a retropharyngeal abscess. Retropharyngeal abscess. And if you see a soft tissue in the upper part, which is extending into the airway like a tongue-shaped projection or a thumb-shaped projection, this is called as a thumb sign of acute epiglottitis. A thumb sign of acute epiglottitis. Whereas what you see here is what is called as a steeple sign of ALTB. Steeple sign of acute laryngotracheobronchitis. A steeple sign of acute laryngotracheobronchitis. Okay. Very, very important that I want all of you to be aware of. Okay. Now let us see these images. What do we see in these images? I hope all of you can see this is the sagittal image and this is the transverse section. If somebody has a problem, do let me know. A sagittal section and a transverse section. What are these images? Are these CT or MR? Are these CTs or MR? These are CT scan. Look at the cortical bone, which is so white. Are these contrast enhanced CTs or the non-contrast CTs? These are definitely the contrast enhanced CTs. There is no doubt. And you can see the entire aorta. Now, what is striking to me is there is a flap kind of structure that is present in the aorta. A flap kind of structure that is present within the aorta, which is giving it a typical double lumen or double barrel sign. A double lumen or a double barrel sign. So this is a classical image of aortic dissection. This is a classical image for aortic dissection. Aortic dissection. On a transverse section, you can also see the flap so very well seen in the aorta. Okay, in the aorta. All right. Apart from the neuro, another image that examiners are very, very fond of is chest X-ray. In your exam, you're gonna see at least 4 to 5 chest X-rays. Okay. Fracture of the spinous process of the C7 vertebra is called as Clay-Chauveler's fracture. Clay-Chauveler's fracture. So according to me, Clay-Chauveler's fracture is a better name because it used to happen in those. Now those people who used to shovel the clay below their head like this. So whenever they used to do hyperextension, the spinous process used to get fractured, and which is called as a Clay-Chauveler's fracture. Okay. Now, if you see this particular image, this is something which is very, very frequently asked in the exam. I can say that your paper is not complete if you do not see this image in the exam. This will be there in the paper. Anybody who can give me the answer of what is the image that has been shown to you? You can see air on this side. You can see air on this side. What is the difference? What is the difference? But a line versus dot principle, if you want to learn, just go to my YouTube channel, and in the YouTube channel, just write line versus dot Dr. Rajat Jain. You will see a video, and I have explained very, very decently about that line versus dot principle. Okay. This is more about images, so let me limit myself to the images, but you're gonna get it easily. It's a three-minute video. You will learn it in a pretty decent way. Okay. All right. So both sides you see the air, but what is the difference? The air on the left side is appearing more black, and it does not have the vascular marking. So area of hyperlucency devoid of vascular marking is pneumothorax. Area of hyperlucency devoid of vascular marking is pneumothorax. Okay, so that's a classical image for a pneumothorax. But the point to be noted is that what is happening because of this pneumothorax? Because of this pneumothorax, the trachea is pushed towards the opposite side. The diaphragm is pushed down. If the trachea is pushed towards the opposite side, diaphragm is pushed down. This is tension pneumothorax. This is tension pneumothorax. The trachea is pushed towards the opposite side. The diaphragm is pushed down. So this is a case of tension pneumothorax. Tension pneumothorax. Okay. All right. Now what do you see here? Now this is a very important image. There are very high chances that you're gonna see this image in the exam. I'll just try to explain it to you. Now see, this is a coin. Okay. Now if the child has swallowed a coin, the coin can enter into the esophagus, coin can enter into the trachea. If the coin enters into the trachea, it has to pass through the vocal cord, and if it will pass through the vocal cord, it will be seen like this in the image. However, if it is in the esophagus, it will be seen like this. So the coin is seen as flat on a frontal radiograph. It is likely to be in the esophagus. If it is seen end on, it is in the trachea. So this is coin in the esophagus. A lateral radiograph can clearly show the airway in front of the coin. So this is a coin in esophagus. Please remember, if the coin is lying flat, then it is present in the esophagus. If the coin is seen as end on like this, that means the coin lies in trachea. Okay. All right. Can you tell me, what do you see here? What do you see in this particular image? This is also very commonly asked image in the exam, and just by seeing this image, you should be able to identify. What do you see here? Now, what do we see in this particular image is, you can see the diaphragm, right diaphragm, but you do not see the left diaphragm. So you can see the right diaphragm, but the left diaphragm is not seen. And what do you see are, you can see that the bowel loops are herniating into the thorax. That's a classical image, very frequently asked in the exam, and that is CDH, congenital diaphragmatic hernia. Congenital diaphragmatic hernia. Okay. Now, what do you see here? Now, this is a slightly difficult image. Now, ignore this arrow. What we are seeing is, you are seeing the air density present in the subcutaneous tissue here. Air density present in the subcutaneous tissue here. So that's a classical image of a subcutaneous emphysema. Please make a note of it. That's a classical image of a subcutaneous emphysema. Soft tissue should not have an air lucency, and if we are seeing an air lucency in the subcutaneous tissue, that's an image of a subcutaneous emphysema. Okay. All right. Now I have two images for you over here. Now just try to pay attention to this. Now what you are seeing is, you are seeing the heart which is outlined by air. Outlined by the air, which is very clearly seen. So it is outlined by the air. Air is pneumo. This is a case of pneumopericardium. This is a case of pneumopericardium. See, cardiac tamponade is a compression of the heart, as a result of which it is not able to expand. That's cardiac tamponade, which could be because of pericardial effusion, which could be because of pneumopericardium. This is pneumopericardium. Okay. Whereas what is happening is, in this case, heart is encircled by the water. So this is a case of pericardial effusion. This is a case of a pericardial effusion. So this is pneumopericardium, and this is pericardial effusion. Now this could be because of dilated heart also, rather than the fluid. But if it's a dilated heart, you're gonna see the entire heart is dilated, and the upper or the superior mediastinum is also widened. When the superior mediastinum is narrowed and you see entire globularity only in the lower part, this is called as money bag appearance. Money bag appearance. And money bag appearance is a very important feature. Money bag appearance is a very important feature of pericardial effusion. Okay. Now, if the pericardium is calcified, as one of the student is asking, please remember, the most common cause of pericardial calcification is TB. Okay. Then it looks like that there is a cup and the heart is sitting in the cup like an egg, and that is what is called as an egg in a cup appearance. So egg in a cup appearance is a feature of pericardial calcification or a constrictive pericarditis. Okay, all right. So moving from the chest to the abdomen, these are very, very frequently asked images in the exam. Image number 1, image number 2, and image number 3. Can you tell me what is the diagnosis of the 3? Image number 1, what do you see is a dilated esophagus with sudden narrowing, a short segment narrowing, which is called as bird beak appearance. Bird beak appearance, which is a feature of achalasia. Bird beak appearance, which is a feature of achalasia. Whereas what do you see here? You are seeing a long segment, slightly irregular narrowing, which is called as rat tail appearance, which is a feature of carcinoma esophagus. An important point that I want you to pay attention to here is that sometimes you can mix the two, and that is absolutely okay. So the dysphagia is predominantly to liquid. It should be motility cause. And if the dysphagia is predominantly to solid, look at cancer. So you have to see the language, you have to see the history, what is given, and that will also help you in reaching to the diagnosis. Okay. Whereas this is called as corkscrew esophagus. Corkscrew esophagus, which is a feature of diffuse esophageal spasm. Corkscrew esophagus is a feature of diffuse esophageal spasm. What do you see here? This is also barium swallow. Whereas in this barium swallow, what do we see is we are seeing that there is a contrast filled out pouching in the upper part. And this is what is called as a pharyngeal pouch. This is what is called as a pharyngeal pouch, also called as Zenker's diverticulum. Pharyngeal pouch, also called as Zenker's diverticulum. Okay. Now the diagnosis of this image is written over here. I want you to tell me the name of the signs that have been shown to you. So if you see this sign, anybody who can tell me what is happening is this is happening. What is this? A claw sign or a pincer grasp deformity. A claw sign or a pincer grasp deformity, whereas this is called as coiled spring appearance. This is called as a coiled spring appearance. Claw sign or a pincer grasp deformity or a coiled spring appearance. Whereas if you see this, this is bowel within a bowel appearance. Bowel within a bowel appearance, also called as target sign, also called as donut appearance. And it looks like a donut. A target sign or a donut appearance. Okay, so these are the important signs that you can see in intussusception in radiology. Again, very, very frequently asked in the paper. Again, your paper is not complete without image that I am showing you right now and one more sister image to that. Can you tell me what is the diagnosis of this image? Anybody? What we are seeing? We are seeing multiple air fluid level at different level. So multiple air fluid level at different level, think of small bowel obstruction. Multiple air fluid level at different level, you are seeing step ladder pattern. You are seeing what is called as a typical image of a small bowel obstruction. Now these air fluid levels are seen because you are seeing the fluid as well as air. Sometime when the entire bowel loop is filled with fluid, these air fluid levels are not seen. But in these cases, small foci of the air are seen adjacent to the wall. Small foci of the air are seen adjacent to the wall, as you see here, and this is what is called as a string of bead appearance. String of bead appearance. Now it is to be noted that the string of bead appearance on an X-ray abdomen is also a feature of small bowel obstruction. String of bead appearance is also a feature of small bowel obstruction. Okay. Anybody who can give me the diagnosis of this image, take 30 seconds and tell me the answer. Now you are seeing the air outlining the psoas muscle. If air is outlining the psoas muscle, you are thinking it's a free air, but you know psoas is not a part of peritoneum. It is behind the peritoneum. So this is not pneumoperitoneum. It is actually, yes, anybody? Retroperitoneum. Yes. Your eyes can't see what your mind doesn't know. So let your mind know that there is something called as a pneumoperitoneum. There is something that is also called as pneumoretroperitoneum. This air is behind the peritoneum. It is outlining the kidney and the psoas muscle. So this is a pneumoretroperitoneum, not pneumoperitoneum. Okay. Now this is also common image that is asked in the exam. 1, 2, 3. Anybody who can tell me what is the name of the investigations? What investigation that have been shown to you? So please remember, you can see the common bile duct, you can see the pancreatic duct, and rest everything is totally black. So if you see such an image, you are dealing with a case of MRCP, which is magnetic resonance cholangiopancreatography. Magnetic resonance cholangiopancreatography. Do not mistake it with ERCP. In order to qualify for an ERCP, you need to see a endoscope, because ERCP stands for endoscopic. The name says endoscopic retrograde cholangiopancreatography. Endoscopic retrograde cholangiopancreatography, and that is what is called as an ERCP. ERCP. Okay. Whereas this is what is called as a T-tube cholangiogram. T-tube cholangiogram. The T-tube cholangiogram, where a T-shaped tube is placed in the central part of the common bile duct, and that's a T-tube cholangiogram. Okay. Now, these are the normal images that I have shown to you. There are some diseases here. Now, if you see this particular case, this is a difficult image. It is unlikely to be there in a screening paper, but just in case, you are seeing the intrahepatic biliary radicals, which are alternatively dilated and constricted, multiple intrahepatic biliary radical strictures. This is a typical image of a disease which is called as primary sclerosing cholangitis. Primary sclerosing cholangitis, whereas in this case you are seeing a dilated CBD with filling defect in the lower end of the CBD. A dilated CBD with filling defect in the lower end of the CBD, and this is choledocholithiasis. This is choledocholithiasis. What is a choledocholithiasis? Stone in the CBD. So that's an image of a choledocholithiasis. Okay. So MRCP, ERCP, T-tube cholangiogram, choledocholithiasis, these are the must. Primary sclerosing cholangitis is optional. This is an image which is very frequently asked in the NEET PG nowadays, and as well as in the INI CT. There are chances that you're gonna get this in the future FMG exam also. Now this is a B mode ultrasound, and this is an M mode ultrasound of the lung. So when you do a B mode ultrasound, which is a real-time ultrasound, you see skin, subcutaneous tissue, intercostal muscles, and then you see a clear junction of the parietal and the visceral pleura. You see a very clear junction of the parietal and the visceral pleura, and when you do a real-time ultrasound, you can see the movement of the parietal pleura over the visceral pleura. I hope in this real-time ultrasound, you can see this movement, and this is what is called as sliding pleura sign. Okay, a sliding pleura sign or a seashore sign. Now it is to be noted that both the signs are normal. Okay. However, when we see this image, now what do you see is, now in a pneumoperitoneum, what is happening is air is coming between the parietal and the visceral pleura. So if air is coming between the parietal and visceral pleura, you do not see this movement. And this is what is called as loss of sliding pleura sign. Loss of sliding pleura sign. And now since the visceral pleura is not seen, then the junction between the parietal and visceral pleura is also completely lost. And you all see just these parallel lines, which is called as a barcode sign or a stratosphere sign. So please remember, a barcode sign or a stratosphere sign or an M mode or a loss of sliding pleura sign, all are seen in pneumothorax. All are seen in pneumothorax. So that if you can remember it, it might give you one extra mark in the exam. Seashore sign, sliding pleura sign are normal. Barcode sign, loss of sliding pleura sign are abnormal. Okay. All right. What is this? Now this again, I want to tell you something. Please remember, this is what is called as a Mickey Mouse sign. Mickey Mouse sign. And this Mickey Mouse sign is a normal appearance of a saphenofemoral junction. It's a normal appearance of a saphenofemoral junction on ultrasound. Mickey Mouse sign is a normal appearance of the saphenofemoral junction on the ultrasound. It is the area where the great saphenous vein is draining into the femoral vein and you are seeing the femoral artery. This becomes more pronounced in varicose veins and when there is an incompetent saphenofemoral junction. But please remember, this is a normal appearance. Okay. We have already seen these images. I hope it is very easy for you to identify that this is an IVP as well as this is an IVP. Okay, we have done that in our detailed class as well. But this image is a background of a radiograph. So this is a conventional IVP. This is a conventional IVP, whereas this image is in a background of a CT. So this is a CT IVP. And a CT IVP is also called as CT urography. So all these contrast studies nowadays can be conventional studies, can be CT studies. They can be conventional studies and they can be CT studies. This is a conventional IVP and this is a CT IVP or a CT urography. Okay. All right. Anybody who can give me the diagnosis of this image? Yes. What do you see here? What do you see here? Yes. Tell me quick. Now what we are seeing is a metallic elongated structure into the ureter which is coiled at the top and the coiled at the bottom. So please remember, this is a double J stent, in a common language called as DJ stent. A double J stent, commonly called as a DJ stent. This is not a stone. You cannot have that in elongated stone. This is not an IVP. IVP should have shown you a pelvic calyceal system as well as some dye into the ureter and the bladder and as well as on both the sides. So this is a metallic stent which is called as a DJ stent or a double J stent. Examiners are very fond of asking some stents, tubes in the radiograph. Diagnosis, very simple image, very commonly asked in the exam. What do you see? Terminal end of the ureter is dilated, which is called as a cobra head appearance. A cobra head or an adder head appearance, which is a feature of ureterocele. A cobra head or an adder head appearance, which is a feature of ureterocele. Okay. Whereas what do you see here? The two kidneys are joined in the midline, and that is what is called as a horseshoe kidney. Horseshoe kidney, which is called as a joining hand sign or also called as a flower vase appearance. A joining hand sign or a flower vase appearance. Okay. Whereas what do we see here? In this case, one kidney has migrated to the other side. One kidney has migrated to the other side and which is called as crossed ectopic kidney. Which is called as crossed ectopic kidney. And what do we see here? In this case, I am seeing one ureter on this side and two ureters on the other side. So if I am seeing two ureters on one side and the one ureter on the other side, this is a duplicated system. So this is an image of a duplicated system. Okay. So cross the topic kidney, duplicated system, ureterocele and horseshoe kidney. Yes, duplicated system shows drooping lily sign. That's a normal image. We have already seen that in the past. What is this? This is a normal MCU. This is how a normal MCU look like. Whereas what do we see here? Now you are seeing a bladder and a dilated posterior urethra, and which is called as a keyhole appearance. Keyhole appearance is a feature of posterior urethral valve. So that's a classical image of a posterior urethral valve. Whereas what do you see in these two images? In this image, you can see that there is a reflux of the dye into bilateral ureter. Reflux of the dye in bilateral ureter, and this is vesico-ureteric reflux. This is vesico-ureteric reflux. Whereas what you see here is normal the bladder is like this. In this, the bladder becomes triangular. You are seeing multiple trabeculations and a stem, which is called as a Christmas tree bladder. Christmas tree bladder, which is a neurogenic bladder. A Christmas tree bladder, which is also called as a neurogenic bladder. Okay. Similar to the shape of skull, as we have discussed, shape of vertebrae are also important. So 1, 2, 3, 4, 5, 6, 7, 8. So quickly write it. Then what do you think are the answers? What is this? Bullet shaped vertebra seen in achondroplasia. Fish mouth vertebra, osteoporosis. H-shaped vertebra, H-shaped, sickle cell anemia, Picture frame vertebra, Paget's. Picture frame vertebra, Paget's. Sandwich appearance, also called as rugger jersey spine. Sandwich appearance, also called as rugger jersey spine, seen in renal osteodystrophy. Sandwich appearance, also called as rugger jersey spine, seen in renal osteodystrophy. Ivory vertebra, seen in Paget's disease. So Paget's can show you picture frame, Paget's can show you ivory. Both picture frame and ivory can be seen in Paget's. If one vertebra is collapsed, this is called as solitary collapsed vertebra, which is vertebra plana. Just give me a second. Vertebra plana, which is seen in eosinophilic granuloma, and this is what is called as bamboo spine, which is seen in ankylosing spondylitis. Okay, and this is the last image that you could see. This is a normal HSG. I think all of you can see. Whereas in this case, what you could see is both the tubes are dilated. And once the tubes are markedly dilated, this is a case of hydrocephalus. hydrosalpinx. This is a case of bilateral hydrosalpinx. So HSG or a bilateral hydrosalpinx. Okay, all right. So now if this tube would not have been seen, I would have called it as a cornual block. Okay. So the point to be noted is that that is how the images are there in the exam. Majority of the images are going to revolve around the things that we have covered. Just go through them, just with open mind, try to identify what is the image that is asked in the exam, and I'm sure that you will be able to answer almost any question related to the exam, related to the image. Okay, all right. So that's all. We'll stop for the day. Thank you very much for your time.